So this evening's lecture, we're going to look at hydralazine isosorbide dinitrate uh, pharmacological treatment for stage C heart failure. Then we'll move on to digoxin, and then we'll look at device therapy for stage C heart failure. And the device we're talking about is CRT, which is cardiac resynchronization therapy. That is when we use the biventricular pacemaker. And then the other device we're going to look at is the implantable cardioverter defibrillator. So, and that will wrap up stage C heart failure. And then we'll look at stage D heart failure. So these are the refractory, the real sick patients who either go on to cardiac transplantation or you're going to use some other method to keep these patients out of the hospital or to be symptom free. And so hopefully we'll do that. We'll start that lecture on Thursday. All right, so the hydralazine isosorbide dinitrate combination is a unique one because it's recommended for the African American population, and that is why it's very testable. So all exam this disappears, and if you look at so it gets a class 1 indication. So the hydralazine isosorbide dinitrate combination. So it's a combination. It's not hydralazine alone, and it's not isosorbide dinitrate alone. It is the combination. And that combination gets a class 1 indication. And the statement reads, the combination of hydralazine and isosorbide dinitrate is recommended to reduce morbidity and mortality for patients self-described as African Americans with New York Heart Association class 3 to 4 heart failure with reduced ejection fraction. This is after they're receiving optimal therapy with ACE inhibitors, beta blockers, unless it is contraindicated. So this statement is a very important one, okay? So what it is saying is that patients, African-American patients, Black patients, who are very symptomatic, and if they're on guideline directed medical therapy already, that is the ACE inhibitors, your beta blockers, and mineral corticoid antagonists, you can add to the regimen hydralazine and isosorbide dinitrate. And that combination in the Black groups have been shown to reduce morbidity and mortality. And again, they test this knowledge on all levels of exams. So it gets a class 1 indication. The combination, however, gets a class 2 indication. So a combination of hydralazine and isosorbide dinitrate can be useful to reduce morbidity and mortality in patients with current or prior symptomatic heart failure who cannot be given ACE inhibitors or HARB because of intolerance. So what this is saying is that if the patient is allergic to ACE inhibitors or HARB, or they're just intolerant, or they can't take it for whatever reason, hypotension or renal insufficiency, you can give them hydralazine and isosorbide dinitrate in place of the ACE or the HARB. And it has been shown so these are all groups now, all groups. It reduces morbidity and mortality. So remember, if the patient can tolerate ACE and HARB, that is the first line, that is a class 1. If you have a Black patient and you're still symptomatic on guideline-directed medical therapy, which includes ACE inhibitors, beta blockers, and mineralocorticoid antagonist, then you can add the hydralazine isosorbide. If you have all patients and if they're intolerant to ACE or HARBs, then you can use the hydralazine isosorbide, and that's a class 2A indication, okay? So very important. So, you know, you have choice, so to speak. Large-scale trial comparing the vasodilator, hydralazine, and isosorbide combination with placebo. And when we talk about placebo, usual therapy, you know, some time ago is digoxin and diuretics. So we comparing hydralazine and isosorbide dinitrate with digoxin and diuretics. And it was shown that hydralazine and isosorbide dinitrate reduce mortality, but not hospitalization. And then there were two other studies comparing hydralazine and isosorbide dinitrate with ACE inhibitors. The ACE inhibitor produced more favorable effects on survival. So there were more mortality benefit with the ACE inhibitors. But when they did a post hoc retrospective analysis demonstrating efficacy in the African American cohort. So again, people who are doing exam, question always occur in your exams. Okay, so the combination of hydralazine and isosorbide dinitrate is recommended for African Americans with heart failure with reduced ejection fraction who remain symptomatic despite concomitant use of ACE inhibitors, beta blockers, and aldosterone antagonists. Okay, that's one indication. And the combination may be considered in patients who are intolerant of ACE inhibitors or HARBs. And we have a fixed dose combination with the hydralazine and isosorbide, starting with 37.5 milligrams of hydralazine and 20 milligrams of isosorbide, and we give it 3 times a day. So it's a 3-time-a-day medication, okay? And so this is the starting dose, and you can increase it to 2 tablets 3 times a day. So that's a lot of tablets. So for just the hydralazine and isosorbide dinitrate, that's 6 pills. You're going to be compliance issues there. So what are the risks of treatment? Poor compliance. There's a lot of tablets, a lot of pills, okay? And then the frequent administration 3 times a day. You know, some people remember to take pills once, twice, push it 3 times. It's really, really difficult. The adverse reaction for especially the isosorbide portion, headaches. So a lot of patients cannot take this medicine because of the headaches. A lot of nitrate preparation will give you headaches, and you get dizziness and GI complaints, but the headache is the one that's most troublesome. So if you look at the magnitude of benefit, you can see that the hydralazine nitrate combination, the relative risk reduction in mortality, or the relative reduction in mortality is about 43%. And the number needed to treat for mortality reduction is about 7 in hydralazine. And the relative risk reduction, heart failure hospitalization is about 33%. And you see, you can compare it to your ACE inhibitors, your HARB, your beta blockers, and your aldosterone antagonists. All right. So let's move on to digoxin. I mean, it's a medication that has been around a long time. We still use it. It's still one of our go-to medicine. It gets only a class 2A indication though. So the digoxin in heart failure with reduced ejection fraction is only a class 2A indication. And digoxin can be beneficial in patients with heart failure with reduced ejection fraction unless it is contraindicated. It reduces hospitalization for heart failure. It does not reduce mortality, but it reduces hospitalization. And digoxin inhibits the sodium potassium ATPase pump, and that's how it works. It inhibits the sodium potassium ATPase pump. So if we look at a short duration of therapy, 1 to 3 months, several placebo-controlled trials shown that digoxin does improve symptoms, and it also improves health-related quality of life as well. It also improves exercise tolerance, and this benefit is regardless whether the patient is in sinus or atrial fibrillation. We used to think that digoxin only help these patients who have heart failure with reduced ejection fraction if they're in atrial fibrillation, but the studies have not borne that out. So all comers benefit. But long-term trials now looking 2 to 5 years show that digoxin really have no effect on mortality. And there's a modestly reduced the combined risk of death and hospitalization. Again, it inhibits the sodium potassium ATPase pump. It's an add-on medication, so it's not a medicine that we would start initially. So you're going to have the medication in patients with persistent symptoms of heart failure with reduced ejection fraction during guideline-directed medical therapy if the patient have severe symptoms. So can be add-on medication if the symptoms are severe. But you have to make sure that the patient is on the guideline-directed medical therapy, your beta blockers, ACE inhibitors or ARBs, and your aldosterone antagonists. Okay? You have to be very cautious if the patient have significant sinus or AV block, because digoxin can further block the sinus or the AV node. Okay? Patient taking drugs that can suppress the sinus or the AV node, you have to be very cautious how you add digoxin to that regimen. Okay, you always start low and you can increase. So the starting dose is 0.125 to 0.25 milligram daily. The older the patient, so patients over 70, you want to start at a low, you want to start with a lower dose, the 0.125. You can give that daily or every other day. If the patient have renal function or low lean body mass, those are the patients you want to start a very low dose. You don't want to exceed a plasma concentration of 0.5 to 0.9 nanograms per ml. If you dose the patient and you get a plasma concentration above this level, there's mortality associated with digoxin use, and that's one of the reasons why it only gets a class 2A indication, because if your digoxin level is persistently greater than say 1.1, it has been shown that those patients have increased mortality, and the toxic level of digoxin is 2. It has what we call a very narrow therapeutic index. So the range from being therapeutic to being toxic is a very narrow one. So you have to be careful how you're dosing your digoxin. You have to get periodic digoxin level. So what are some of the risks of treatment with digoxin? So again, you can large doses. Especially in the elderly patients. Some patients are older patients. If they're not seen properly, they may take too much of the digoxin, and they can become very toxic. some of the problems that you get with digoxin toxicity, cardiac arrhythmias. And again, people do an exam, they always put biventricular tachycardia is one of the features of digoxin toxicity. And for some reason, they always put that on the exam. But you can get a series of cardiac arrhythmias, reentrant, different type of heart blocks. GI symptoms with toxicity is very prominent. Usually a older female patient lose their appetite, their nausea, vomiting, and sometimes they can become very cachectic because of the loss of appetite and the nausea, vomiting. Neurological complaint, visual disturbance. They tell you that they have these colored halos that I see, can get disorientation and confusion. And as we mentioned, digoxin toxicity is usually associated with a digoxin level greater than 2 nanograms per deciliter. However, you can become toxic at even a lower dose if the patients have hypokalemia, hypomagnesemia, or hypothyroidism. So again, digoxin has a very narrow therapeutic index. That is the dose that is therapeutic to the dose that is going to be toxic is a small difference. So you have to be careful. You have to evaluate your patients. You have to do vital signs. You have to talk to them, and you have to get digoxin levels. These are some of the medications that can increase the digoxin level. So, you know, if you're doing exams, you'll probably have to memorize them. But if you're not doing an exam, you know, and you're going to treat your patients with digoxin, you know, take out one of your little book, or you can Google it and just make sure, you know, it's not one of these medicines. These are the medicines that can increase the digoxin level. Clarithromycin, which is an antibiotic. Dronedarone, which is Multac in some, okay. Erythromycin, we commonly use that, so you should memorize that. Amiodarone can increase the digoxin level as well. Itraconazole, cyclosporine, so anti-rejection medicine, you know, we use this quite a bit. Renal transplantation, cardiac transplantation, so propafenone, antiarrhythmic, verapamil, and quinidine. So these are some of the medicines that can increase the digoxin level and predispose the patient to digoxin toxicity. So again, low lean body mass, usually elderly patients, impaired renal function. So those are some of the things that will predispose one to digoxin toxicity. What about other medication that we can use in stage C heart failure? So again, remember your stage C heart failure patient is the patient who have structural heart disease and either is now presenting with symptoms or they have had symptoms in the past. So what about anticoagulation? You only give blood thinners if the patient has some type of atrial fibrillation, permanent, persistent, or paroxysmal atrial fibrillation. And you're going to put them through the CHA2DS2-VASc score to see if they're at an increased risk and they need anticoagulation. Okay? So you're not going to routinely give your patient with heart failure with reduced ejection fraction anticoagulation. If they have atrial fibrillation, you put them through the CHA2DS2-VASc score and see if they need it. And then the selection of the agent. So again, remember you have the warfarin, which is Coumadin, dabigatran, which is your Pradaxa, Apixaban, which is the Eliquis, and rivaroxaban, which is Xarelto. Okay, so now chronic anticoagulation is reasonable for patients with chronic heart failure, reduced ejection fraction, well, any type of heart failure, if they have permanent, persistent, or paroxysmal atrial fibrillation, you're going to put them through the CHA2DS2-VASc score. And if they score 1 or greater, you know, then you can give them anticoagulation. Anticoagulation is not recommended in patients with chronic heart failure with reduced ejection fraction without AF, unless the patient have some type of thrombus. So patient with heart failure with reduced ejection fraction, and you do your echo. That's why it's important to do echo in all your heart failure patients. You see something right there, and you put contrast, and usually the contrast goes around it. This is an apical thrombus. This type of patient needs anticoagulation. What about statins? There is no benefit, so you're not going to routinely give these patients statin unless there is some indication, other indication for it. Omega-3 fatty acid, you can give them that, so class 2A. So drugs with no proven benefits, so nutritional supplements and stuff like, it's not going to help the patient with heart failure with reduced ejection fraction. So do not push nutritional supplement, coenzyme Q2, Q10, and all, and vitamin B. Studies have been done. Those medications does not help the patients. Okay. Hormonal therapy only if the patient is deficient and 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 needs, those hormonal therapy. But there are some drugs that can harm the patient. There are some medications that can harm the patient. So be careful of some of the antiarrhythmics. More than 20 years ago, we did a study called the CAS trial, and there were certain antiarrhythmics that actually kill patients who have heart failure with reduced ejection fraction. So now we know not to give these patients those medicines. So certain antiarrhythmics, you don't want to give it to them. Certain calcium channel blockers, your diltiazem and cardizem, you don't want to give it to them. NSAIDs, and this is a thiazolidine. This is a diabetic medicine. Okay, so patients with heart failure with reduced ejection fraction, one of the problems is that the heart is not contracting properly. So if we give them inotropic drug, those are medicines that increase the contractility of the heart, they will do better, but that's only short term. If you give these inotropic drugs long term, they can harm the patient. So that's another thing you have to be aware of. And then these are some strategies for achieving optimal guideline directed medical therapy. I'm not going to read through them. But again, when you're treating your patient, start with the lower dose and gradually increase. You have to see these patients sometime very often to find out how they're tolerating the medicines, make sure that the blood pressure is okay, the heart rate is okay. Especially if you have older patients and patients with kidney disease, you're going to see them a little bit more often. You're going to get more blood tests. You're going to look at their kidney function from time to time, and you're going to get the potassium. Okay. Again, I say you have to monitor these patients closely. During the up titration, you have to check the blood pressure because some of these patients will become hypotensive. And if they become hypotensive, they're going to be lightheaded and dizzy, and they're not going to take a medicine, or they're not going to want to come back to see you. So, you have to be vigilant. If they're not tolerating one medicine, you need to remember that there are other medications that you can use. So if the patient have a cough and say the ACE inhibitor, they're having a cough, and on the HARB, they're not tolerating the HARB, remember your hydralazine isosorbide combination. So you have to remember that. Again, renal function and electrolytes, potassium, because, if some of these medicines can elevate the potassium, high potassium can really, really hurt the patient. So, and the patient, can succumb. So you need to be very vigilant. Fatigue is a vexing problem in heart failure, fatigue and weakness. You will have the patient will be, well compensated, doing well, but they're just fatigued and weak and stuff. That is a problem. So you have to, see what's going on. And beta blockers, even though they're very, very effective and they do all sort of good stuff, they do cause weakness and fatigue. So you may have to switch from one beta blocker to the next, and find out, see how the patient tolerate the medicine. Um, if they tell you that they're fatigued, give them a little time on the medicine. Sometimes it resolves, but you have to pay attention to that, because if the patient is fatigued and weak all the time, then quality of life is going to be compromised. Again, discourage sudden spontaneous you don't want to stop the medication abruptly. Okay, so sometimes you have to gradually withdraw the medicine. And you have to discuss the medication with the patient, and from time to time go over the medication. And you have to educate the patient and their family to the condition and what the medicines are used for. Okay, so let's move on to device therapy. So these are what we call sort of adjunctive therapy. It helps the patient with heart failure with reduced ejection fraction. And for stage C, or device therapy, is basically two. We have the CRT. This is your BiV pacemaker, and on the right hand side we have a heart, and you see this is the pacemaker generator, and we put 3 leads in the patient's heart. We put a lead in the right atrium, we put a lead in the right ventricle, and then this is a coronary, well, we put a lead on the left side of the heart. And we can put this lead, the left side of the heart, we can go through the coronary sinus, and the coronary sinus will lie on the left ventricle, or we can do thoracotomy, and we can do an epicardial lead. We can put the lead directly on the surface of the left ventricle. And remember when we said these patients with heart failure with reduced ejection fraction, they have dysynchrony. And dysynchrony is when different areas of the heart contract at different timing. The contractility of the heart is not uniform. So when we do cardiac resynchronization therapy, is just to coordinate the contractility of the heart so that the heart contracts in a uniform fashion, and the ejection fraction usually goes up. So the cardiac output will improve. And if the patient have any significant, say, mitral regurgitation, that also will improve. So when you do fluoroscopy, this is what it looks like, because you have a lead in the right atrium, okay? You have a coronary sinus lead that go over to the left ventricle, and then you have a lead in the right ventricle that comes right here. And then we just coordinate the contractility of the heart, as opposed to your implantable cardioverter defibrillator, ICD. So the reason why ICD is crucial in these patients is because the mechanism of death in a lot of these patients with heart failure with reduced ejection fraction is ventricular tachycardia, ventricular fibrillation. The heart beats so fast that it sort of stands still. So when you have a implantable cardioverter defibrillator in place, it recognizes when the heart goes into ventricular tachycardia, ventricular fibrillation, and can shock the patient out of that. So the first therapy is to improve cardiac output. This therapy is really to prevent death in these patients. So what are the recommendations? So class 1 indication, ICD therapy is recommended for primary prevention of sudden cardiac death. So when we say primary prevention, the patient has never had an event, never had a ventricular tachycardia, ventricular fibrillation. But because the patient have a heart failure with reduced ejection fraction, and if the ejection fraction is 35% or less, and they have class New York Heart Association class 2 or 3 symptoms, then they're a candidate for ICD, as long as they can live for more than a year. So what we mean by that is they don't have a malignancy that is going to compromise their survival. Or even if they have a malignancy, it's probably slow growing, something like a CLL or something like that. So it's not, they're not going to have a survival less than a year. As long as they have survival more than a year, ejection fraction 35% or less, then they get an ICD. This is a class 1, okay? Especially if it's an ischemic. Right? It doesn't really matter. Ejection fraction less than 35% or less. New York Heart Association class symptoms 2 or 3, and if they have a survival more than a year, they get an ICD. So the biventricular pacemaker, which is the CRT, cardiac resynchronization therapy, which improves dysynchrony, is indicated again if the ejection fraction 35% or less, if the patient is in sinus rhythm, a left bundle, QRS, duration of 150 milliseconds or greater, New York Heart Association class 2, 3, or if the patient have ambulatory 4 symptoms. So what this is telling you, the reason why they have all of this is 35% ejection fraction, 35% alone may not suggest significant dysynchrony. But once the QRS is very wide, especially if you have left bundle, the chance of the patient having dysynchrony is great. So what they're saying is the ejection fraction is low and they have a very high chance of dysynchrony. Then resynchronize the heart, okay? Because you want to improve contractility and that will improve the patient's symptoms. So all of this is basically saying the same thing. Ejection fraction less than, but okay, so this one is slightly different. If the patient had a heart attack and is 40 days post a heart attack, okay, if the ejection fraction is 30% or less, even if the patient is asymptomatic. So a heart attack, 40 days out from the heart attack, ejection fraction 30%. If the patient is asymptomatic, you still give them an ICD as long as they, they're going to live for more than a year because, okay? And then, CRT. So the number you need to remember, because, can become a little bit cumbersome, 35%. So, ejection fraction 35%, and if they, have some amount of symptoms, they're probably going to need a CRT, especially if the QRS complex is wide. And then they're also going to need an ICD, implantable cardioverter defibrillator. Okay? So, I mean, there's a lot of little intricacies there, but just remember 35%. 35%. Okay? 35% will buy them CRT and a defibrillator. So you can get a class 2B indication if you're not sure if the patient is going to benefit because they may have renal failure, they may be very frail, other comorbid stuff. As long as they're going to live for more than a year, you can give it to them. It's a class 2B indication. So don't get yourself bogged down in the class 2B, class 2A Ejection fraction less than 35%, more than likely they're going to need a CRT, that's a BiV pacemaker. Ejection fraction less than 35%, they should need they should get an ICD unless it's contraindicated for whatever reason. Again, the patient should be able to live for more than a year. Okay, there's no benefit for these devices or the CRT if the QRS is well. So okay, remember what I said. The guidelines have changed, and we're going to look at the change because CRT has been shown. There are some studies that show that CRT is even beneficial if the ejection fraction is say 45–50%. So we don't want to confuse it too much, but it has been shown that the CRT is more beneficial in patients with even a little bit higher ejection fraction. All right, so let's stop here, and then our next session will be stage D, heart failure. So these are the real sick patients that need intensive care, and they need mechanical. Sometimes they need mechanical circulatory support. So that is a very well, it's a very interesting group of patients, and we'll talk about LVADs and destination therapy. Okay, all right.